Hello, hello, and welcome, mamas, to the Balanced Mama Project Radio. You are here with Dr. Say, hey, and also Dr. Val.
Hey, hey.
We are here with our special guest, Katerina Jones. She is a registered nurse and fertility educator. Yay, y'all know this is Fertility Month, at least our Fertility Month, not the official one.
Mhm.
She has over or nearly a decade of infertility and reproductive health experience. She is the founder of Full Bloom Fertility, which is an education and coaching practice dedicated to closing the knowledge gap around fertility and reproductive health. She empowers individuals and couples to make informed decisions during their family building journeys. And her practice is grounded in reproductive justice principles, and she works and really focuses on inclusivity, access, and education, especially for the Black and Brown communities.
Mhm.
Katerina, thank you so much for joining us today. Welcome,
Yay.
welcome.
Thank you. Thank you for that warm welcome. I'm really excited to be here.
Oh, we are excited to have you. Oh, I didn't do the disclaimer. Do you want to do the disclaimer?
Yeah, so disclaimer today, as with many of our podcast episodes this month, we just want to note to everyone that we are discussing the perspective of infertility of the birthing person or mother, and that is something that can be a really challenging topic to listen to, and so we just want to make note that that is the topic of discussion for today. So please, Katarina, tell us a little bit more about you and how you came to this work as an RN in fertility.
Sure. Yeah, so I have been a nurse for just about 10 years now. This year will be 10 years, and I've been working in reproductive health exclusively for my nursing career. I actually started out in abortion care. So I was an abortion care nurse first. I did that for about a year and a half. Really great experience, really empowering, like just spending time doing that kind of nursing, I think was really impactful for me in terms of defining sort of my career trajectory in nursing. And then I pivoted to fertility care, which to some folks, I guess would kind of sound like a 180, degree turn. But honestly, I just believe in supporting people across the entire reproductive spectrum, and in line with the reproductive justice principles of the right to not have children and also the right to have children. So that kind of just defines, the work that I've done. And so when I got into the fertility space, it was really a little bit jarring for me in the beginning, honestly, because it was for a couple of reasons. One is that fertility nursing is just extremely difficult to learn. Like the learning curve is very steep. It takes at a minimum 6 months to really feel comfortable in fertility nursing, to like really learn the protocols, the medications, like how to coordinate and manage all these different people and all these different moving pieces. And then an additional 6 months to really like feel super, super comfortable. So it wasn't until about a year that I was like, okay, I can answer pretty much any question that a patient throws at me, right? Which in the scheme of just like nursing and nursing specialties, that's a really long time to feel truly comfortable, like in a particular specialty. So that was what kind of surprised me in the beginning. And then also, coming from abortion care, I was serving a very different demographic of patients. And so pivoting into fertility, the demographic of patients that I was serving was very different. Less diverse, more socioeconomically advantaged. And so with that comes a certain amount of, um, I would say just I would say entitlement in certain ways, because oftentimes, at least back in the day, you had to really have money to be able to afford fertility care, and you still do. But when I started in fertility in 2018, the only businesses and companies really that were covering any kind of fertility care was tech companies. And
Mm.
so, more often than not, to work for a tech company, you have to have a certain level of education. You oftentimes have to have advanced degrees. And so, with that, just kind of naturally comes a certain socioeconomic status and capability that I just wasn't really seeing in the majority when I was working in abortion care. And so that was an adjustment for me as well, because, it was just a different demographic that I wasn't used to serving. And so as the years have continued and fertility care has become more accessible than it was before. It definitely has a long way to go still. But, then the demographics started to change. I started to see more Black and Brown patients. But in the beginning, that really wasn't the case. And as I point out a lot, that I am still the only Black fertility nurse that I know in real life. I've never worked with another Black fertility nurse in almost 10 years
What?
of doing it. Yeah, yeah, it is very much not an industry that is reflective of the people who do need it the most. And, we can talk about statistics and things like that, but, Black and Brown communities are the ones who are mostly being affected by infertility, as the research shows over and over again. And that's not really who's present in the industry and who's kind of like the most involved in it and who's running it and who's, creating startups and companies and things that are geared towards fertility care. So there's a lot there that we can continue to talk about, but that's kind of how I got into the field. It was a little bit by happenstance. I knew that I wanted to continue on in healthcare, in women's health and reproductive health specifically, and so I kind of just fell into fertility. And initially I didn't know if I was going to stay in it, but because of all the things that I talked about, I really started to see that representation matters a lot. And so instead of exiting the specialty because I wasn't really serving the populations that I really wanted to serve, at least in the beginning, um, I decided to stick with it and was like, well, Black and Brown people do experience infertility, and so they should see themselves represented in their clinical staff. And so then it took on a different meaning for me, just what it looked like in my clinical practice, in my clinical life as a nurse.
Yeah. Thank you for
Mhm.
that. Thank you for sharing all of those things.
Yeah.
Every single thing that you touched on is something that we want to hit on in this episode.
Hmm.
It's so important, namely and chiefly the representation, having being representative of patient population that often gets overlooked, um,
Hmm.
yeah,
Underserved.
and underserved, um,
Hmm. Hmm.
and mistreated, and all of the things, right?
Right.
So important that you're doing this work. So, one, thank you for the work that you're doing
Yes, thank you.
tremendously. So to start off, we want to make sure that our listeners, there are a lot of different ways that people can seek fertility treatments, and so
Hmm. Hmm.
that our listeners are on the same page.
Hmm.
Do a
Hmm.
little bit of explaining about the differences between IUI versus IVF,
Hmm. Hmm.
common assistive fertility terms that
Yes.
I'm familiar or unfamiliar with.
Sure. So yeah, we can definitely start off with some basic definitions. So let's start off with just ART. So assisted reproductive technology, or ART, kind of is the umbrella term for any assisted reproductive treatment. So that includes things like IUI, which I'll define in a second, IVF, and fertility preservation procedures, egg or embryo freezing. So that's the term that's like the overall general umbrella is ART, assisted reproductive technology. IVF is in vitro fertilization. That refers to the combination of egg and sperm in a lab. That's like the basic definition of IVF. It seems really simple, but there's so many steps to get there. And so, but the basic definition of IVF is just like the combination of egg and sperm in a lab to create an embryo. IUI, or intrauterine insemination, is when we are inseminating, or basically placing sperm that comes from either your partner or a donor. It could be anonymous donor or a donor that you know, but basically we are placing sperm into the uterus, like manually. That's an intrauterine insemination. And then we have egg or embryo cryopreservation, or freezing. So when we are freezing just the egg gamete, not like, this is important to know. An embryo is the combination of egg and sperm together, and that is what grows into an actual fetus or a baby. The egg separately in and of itself and the sperm separately in and of itself are called gametes. And so we have egg freezing, so that's just freezing the eggs. not combined with sperm. We have sperm freezing, just freezing the sperm, not combined with eggs. And then we have embryo freezing, which is when the two of them come together and we are freezing the embryo itself. There's also TIC, which is timed intercourse, that isn't like talked about as much because timed intercourse is a very low intervention kind of treatment. So most people don't really include that in the assisted reproductive technology umbrella, but it is a part of some of the treatment modalities that people can access or that people can, explore when they are facing infertility, just depending on what their particular situation is, if that's like something that is right for them.
And can I ask you a follow-up question about the timed intercourse? Because
Mm-hmm.
I wonder, is a component of that something that maybe individuals already are doing in terms of
Mm-hmm.
technologies that are coming out, tracking the cycles, making
Mm-hmm.
having intercourse at a particular time when tracking their temperature and things like that. Is that something that people are already leaning into, or is that something that is termed that if a provider is walking them through that step?
It's more so the latter because there's a little bit more intervention that takes place in a timed intercourse, which usually involves the taking of some kind of stimulating drug, like an oral medication that stimulates the follicles to grow, so that at least one, good egg will be ovulated. Sometimes more than one, like one or two. So you usually will take medication to stimulate the follicles, and then you may or may not also take a medication to prompt ovulation or like manually get you to ovulate, which is called like Ovidrel or Pregnil. It's HCG is the same hormone that gets emitted when you become pregnant. So you literally take an injection of HCG, and that is what signals to the body to ovulate. So we're able to time the intercourse very specifically around when we are sort of manually manipulating ovulation and the growth of the follicles. So it's like it is a lower intervention and it does kind of more so follow the body's natural processes, I guess, but we are intervening slightly.
Yeah, yeah, that makes sense. That makes sense. I see why you say that it's a low intervention, but there still is intervention there, which makes it
Right.
the ART umbrella.
Correct.
Yeah,
Correct. Correct.
yeah.
Hmm.
I'm glad you asked that question because I too was curious. I was like, are people already doing this?
Yeah, it's not super common. I mean, and honestly, by the time they get to an REI or a fertility specialist, they have probably already done that because a lot of OBGYNs will sort of do that as like a low level, like intervention like process that you don't necessarily have to see a fertility specialist to do a time intercourse cycle because OBGYNs can prescribe the medication that you would take. I just feel like there's less monitoring involved, and it's kind of like, okay, well, we can try this, but OBGYNs are not like, their specialty is not fertility treatment, like they just have a different, I think that's an important distinction to make because I do think that some people don't really understand that is that OBGYNs are not trained additionally in reproductive endocrinology. That's like that is for a fertility specialist, an REI, who has additional training in really getting people pregnant and all of the different technologies and treatments that we use to do that.
So say more about that. I
Oh
think we
yeah,
probably had this.
Yeah,
yes. I was
yeah,
at that point. Usually, so who is usually on the fertility team? If there's a team,
right,
is the team approach, or is it usually an independent
right,
specialist is running the care? Who are
sure.
the members of the team?
And can I ask like a clarifying question with that too? With this team, could you distinguish between who are fertility specialists on this team versus who maybe have adjunct therapies, adjunct treatment
Right.
helpful still in the team aspect? Does that make sense
Are
too?
you saying like
Yep, yep.
or like yes?
Yeah.
Okay, I got you.
Yes. No, that makes sense. Okay, so usually the general flow is like how people end up accessing a fertility specialist just to begin with is typically they have already been in communication with their OBGYN, and their OBGYN has done what they do. Either they've done a time intercourse and that's not working, or their OBGYN is like, hey, I'm seeing some kind of abnormalities or something like that. Or people have been trying for a certain number of months and not having success. And then they're like, hey, there might be something here. So an OBGYN, it will then say, okay, I'm going to refer you to a fertility specialist, or, I'm going to put you in touch with someone who will be able to give you more of a specialized treatment. And that would be an REI, or a reproductive endocrinologist. Once they come into a reproductive endocrinologist office or clinic or whatever, there's the reproductive endocrinologist. There may or may not be nurse practitioners who are trained, usually on the job. They don't have like additional training courses or something like that that they usually go through to work in a fertility clinic. They usually have some kind of OBGYN experience, but for me, or what I've seen, is that the REI who runs the clinic or is working there is usually training the NP in real time on how to do transvaginal ultrasounds, how to measure the follicles and things like that. So they usually get training on the job, and you have NPs who work in fertility clinics that they can see like new patient appointments, they can do monitoring scans and stuff like that, but they don't do like egg retrievals, embryo transfers, they don't do the actual procedures. So, and some clinics have them, some clinics don't. So an REI plus or minus a nurse practitioner, then you have your nursing team like myself. So we are the people who are coordinating your cycle. So we are ordering your medications. We're creating a treatment calendar for you. We are coordinating with the insurance companies for prior authorizations. We're giving you all of the treatment education, how to inject yourself, what are the side effects. And then when you're coming in for your monitoring appointments and you're seeing either the physician or the nurse practitioner who did your scan and is like counting all your follicles and stuff, the nurses are then reviewing the labs, getting the treatment plan from the physician, and then relaying that information to the patient and saying like, okay, we're going to increase your dose or decrease your dose or continue on this medication, or you're ready for your egg retrieval. These are the instructions for that. So it's almost like, treatment coordination essentially is like the main role of the nurse. And then we also assist with procedures like the nurses do, which are done by the reproductive endocrinologist. And the nurses are there assisting. Sometimes, depending on how big the clinic is, they have just a surgical team or procedure nurses who are just focused on doing procedures. And then they also have the treatment coordinators separately. I've done it with both models where I'm doing treatment coordination and I'm doing procedures, which is a lot. But yeah, so that's kind of the team, like the core team when you're in. And then, of course, there's the embryology team who is in the lab and they're making all the magic in the lab. And you have medical assistants who are doing the blood draws, etc. As far as the adjunct services, like acupuncturists and stuff like that, like there are acupuncturists who are specifically trained in fertility acupuncture. Um, they're We would refer to them as adjunct or additional kind of services. They're not like in an REI clinic. They're not like included in a fertility treatment team. But if we're talking about holistic approaches to treatment, highly recommend acupuncturists, massage therapists, chiropractors, um, pelvic floor therapists, of course, like yourselves, who have like who have maybe like additional training sort of in like reproductive, issues, somatic like body workers and things like that. So those are all like adjunct services. They're not a part of the core fertility team like in a clinic, but they are incredibly helpful for people in many different ways, even if it's literally just managing the stress that comes along with going through fertility treatment, promoting blood flow to the reproductive organs, which can help like improve outcomes, things like that. We still definitely recommend for folks to pursue. And then, of course, also mental health therapists. Like that cannot be understated of how important having some kind of mental health provider on your care team when you're going through fertility treatment is really crucial.
Yes, absolutely. We were actually just chatting with a mental health therapist on another episode for this,
Oh, nice.
talking about fertility and things like that.
Yeah, yeah.
For days about it, but and you were mentioning the with talking about the team, it kind of came up about the coordination of care and just um,
Mm-hmm.
also thinking about how many different individuals are a part of a care team.
Mm-hmm.
Can't help but think about how much money that is
Mm-hmm.
and
Mm-hmm.
time to go
Yes.
to these appointments. And so, can you speak a little bit on the the investment of time and money
Mm-hmm. Mm-hmm.
into the process of the fertility journey. Um,
Yeah.
are there any ways in which people can have financial assistance? How does this work? We know right? We live in America.
Yeah.
For those who might be listening abroad, we are in the United States, and so this is, you know, we are where we are
Yeah.
here. But please speak to that aspect of this care.
Yeah. It's no secret that IVF is very expensive. You know, we're talking, and when we say expensive, I'm talking anywhere between 15 to $30,000 for one cycle. And oftentimes people need more than one cycle in order to really get success.
Hmm.
One cycle means like from beginning to end, the stimulation of the ovarian follicles to produce as many eggs as possible, to then go in and have an egg retrieval and create an embryo, or freeze your eggs or whatever, from start to finish. Like, that's considered one cycle. And a lot of times people need more than one. So if you're paying out of pocket for that, you can very easily spend like $60,000 on something that isn't even guaranteed to give you a baby. So that's like a very real thing, that it is what it is, right? Um Now, if you have insurance coverage through your employer, that does bring the cost down significantly. It does not make it free. A lot of insurance coverages, it depends. Some will cover only the diagnostics, but not the actual treatment itself. Some will cover only the treatment itself, but not the medications. And the medications themselves are anywhere between $4,000 and $7,000 for one cycle, right? So it really, I know it, like, you're like, it's hard to wrap your mind around how much money it really costs.
Yeah.
And for a lot of places, IVF and fertility care is still considered elective, meaning that, like, there is not like a medical necessity. But we know that it is, though, and that's part of the reproductive justice movement. And like, fertility justice is the right to be able to build families and to have children. And if there's a block on that in any kind of way, then we are entitled to care that is affordable and that is like safe and good, to be able to build the families that we all deserve and that we all have a right to. So that's the cost investment. If we're talking about time, that too is, it can vary wildly. I would say the minimum amount of time, if you get super lucky, you enter fertility treatment, you go through one cycle, you get pregnant, and you're done, is at least 3 months from the time of like getting all of your testing done, making sure all of your diagnostics are complete, actually starting the cycle, and then and then waiting for your positive, and then we do two ultrasounds at like 6 weeks and around 8 weeks, and then you graduate to your OBGYN. That's the absolute minimum amount of time frame I think I've ever seen for a patient in fertility.
Hmm.
Maximum could be years. I mean, we don't know how long it will take you to conceive. I've had patients who have gone through 6, 7, 8, 9 rounds of IVF, have done 5, 6, 7, 8 embryo transfers. Like, it just really can take a crazy amount of years, a crazy amount of time. That's just like the treatment time overall. When you're actually in a cycle, you're going into the clinic every few days for monitoring appointments. Like, once you actually start the injections, you're going in like every 2 to 3 days for monitoring, so that they can check how your follicles are growing. The follicles are what contain the eggs on your ovaries, for folks who don't. No, I just want to make sure that I'm explicitly defining these things.
Yeah.
Because I didn't know what follicles were at one point.
Yeah.
Um, so the ultrasounds to check the follicles to see how they're growing, to see how the medication is having an effect on your body requires very close monitoring because everything in IVF is so time sensitive that like you have to catch things within a very particular window, right? Unless or you'll risk ovulating and then we'll lose all of the eggs that we just like grew. So it's that like people taking time off work. Then on top of that, you don't have IVF like centers or fertility clinics everywhere. I've literally had patients who have driven 6 hours one way just to come to the clinic for a monitoring appointment or their procedure or whatever, and then have to drive back. Or they usually will like get a hotel and stay overnight and then drive back the next day. Like, this is the level of just sacrifice and the level of what it requires to really sometimes have outcomes in fertility care. Like, and I think that that is something that like can't be talked about enough because people really need to know. And this is part of why I do what I do, is that I really want to give people this information before they even step foot into a fertility clinic, right? Of like, hey, this is what to expect, because that was the number one thing that people would tell me. My patients will always just say, I just didn't know. I wasn't what like I just wish I would have known like what to expect. I wish I would have known how much this was going to take, how much it was going to cost,
Hmm.
the toll that it was going to take on my mental, my physical, like the time commitment, all of those things
Yeah.
folks literally have no idea about until they are in the throes of it and they're already filled with so much anxiety and so much like hope. They're coming in with already a lot of just like emotional, load, so much of an emotional load that to then have to deal with all of these like really stressful pieces that are required in order for fertility treatment to be effective and to work is just like it's overwhelming, and it can really just be all encompassing.
Absolutely. So to that effect, I think one thing we really want to get across is what is that physical impact, mental
Mm-hmm.
impact, social impact,
Mm-hmm.
and then if you can break those down for us, then maybe we can also kind of follow up the conversation. Like, I'm curious about the external factors
Mm-hmm.
on that are outside of the control of the birthing person that they should be aware of that might be affecting infertility.
Okay. So in terms of the physical impact of going through fertility treatment, so these injectable hormones, they can really do a number on folks, like just like mentally in terms of mood swings, really just like feeling like I've had patients tell me they've had brain fog. They just like they're swinging back and forth. They don't know. They feel crazy. Like I've had patients tell me that they're like, I just feel crazy. They're snapping at their partners, things like that, and you can feel really bloated. So the actual like what's physically happening is that the hormonal injections that you're taking are stimulating the growth of the follicles on your ovaries. Typically, your ovaries are about the size of like your thumb, kind of. And so when you're taking these fertility injections, they can get as big as like your fist, even like a grapefruit. I've had patients like who you can, if they lay flat, they can literally feel like their pelvis like bulging a little bit on both sides because the follicles, they've gotten so big because we're growing all of these follicles at once. Usually in a regular menstrual cycle, only one follicle is growing and becomes the dominant follicle, and that's what gets ovulated. But in fertility care, and when you're taking these hormonal injections, we're growing all of the follicles on your ovaries. And so it's like little balloons that are literally just growing over the course of 2 weeks. So it can cause a ton of bloating. It can cause like sharp or dull pains in your pelvis, your abdomen. The hormones can make you lose sleep. Like it can cause insomnia. A lot of the things that folks experience, like menstruating folks experience around PMS, like before you get your period, breast tenderness, that kind of thing. That's what gets amplified when you're in fertility treatment, like when you're taking the hormones. So Yeah, it has a significant physical impact. In terms of emotional, I kind of touched on that a little bit too, like the hormonal swings. It can really do stuff to, your relationship with your partner. If you're doing this with a partner, oftentimes they have to be really like understanding of these things that you're going through. You may be a little bit more short tempered, you may snap at your partner a little bit more, you may feel extremely fatigued, which is then going to just reduce your capability to do activities. So then that's moving on to the social impact. You may not want to go out and do things that you typically would. You have to plan your life around fertility treatment, not the other way around. So when you're in the actual cycle, that 2 week period of when you're taking the injections and stuff like that, you have to be available because you're going into the clinic multiple times every other day, or every 2 days or whatever, for appointments. You can't go on a trip. You can't just have a spontaneous weekend away. Because everything is so time sensitive, when we say that we need to see you in clinic, we have to see you in clinic. So now you're arranging your entire social and professional calendar around fertility treatment.
Mm.
So that's like a huge social impact too. And then, of course, there's just, I don't want to go to this baby shower. I'm trying to conceive. I've been trying forever, every time someone pops up with another pregnancy announcement, friends, family, it having to field those questions when you go to family and social gatherings, like, oh, when are you guys going to have a baby? When, why is it taking so long? Like, and generally speaking, people are well meaning, but it can be incredibly intrusive to ask people questions like that because you just never know what folks are going through. So, like, folks will literally avoid going to social gatherings because they just don't want to have to deal with people asking them questions,
Mm.
about their conception and like their family building journey. So it really, when I say like fertility treatment can really truly be all encompassing, it really does hit like every aspect of your life, your relationships, your physical, like your body, your mental health. Um, you know, it really is a lot that people are dealing with.
It really is. It really.
Hmm.
So I am curious, in our last moments with you today, I am curious about when people usually come to see you. We,
Hmm.
as healthcare providers, that, you know, if you have been trying a maybe traditional
Hmm.
method for
Hmm.
about a year and with
Hmm.
this, then it is time to see people. But given the cost, given the
Time.
Yeah.
investment, all of these things, that
Hmm.
you mentioned, when do people actually usually like?
Yeah.
How long have they waited, or are they more
Proactive. I don't want to say
proactive?
proactive,
Yeah,
but
Proactive. Yeah.
yeah, sooner rather than later. Like, how's that work?
Yeah, I think it really depends. I mean, the guidelines say that if you are under the age of 35 and you have been trying for at least a year, then you need to go see a specialist because 80% of people under 35 will conceive within a year. So, it sometimes might just take a little bit longer. Each period cycle, you only have about a 20% chance of conception. So it can just take longer. And so sometimes people will start to freak out if they haven't gotten pregnant after like 6 months or whatever. But, you know, sometimes it just takes longer, right? And that doesn't necessarily mean that there's anything wrong. But if you are over the age of 35, if you are 35 or older, then the guidelines reduce that to 6 months of trying. So if you've been trying for 6 months and you're not having success, then you should see a fertility specialist. Then there's something called social infertility, which is where there are relational, structural things that are in play that prevent you from having a kid. So this applies usually to LGBTQIA plus individuals who require assistance building their family. So if you know that already, then like you're gonna have to seek a fertility specialist. It doesn't really matter how long, it's just when you're ready to have a baby, right? Um, or for single parents by choice, who require assistance. So I would say, but then it gets tricky because it is so expensive. Sometimes people will come for an initial consultation, but they don't have the money. So then they will just kind of keep trying on their own for a little while, and then maybe they'll come back to save up and stuff like that, and then they'll come back. So that's the definition or what the guidelines are of like when you need to see a fertility specialist. But I personally think that like if you've been trying, or if you know your body usually better than anybody else, if you feel like there's a problem or you're feeling like, I don't know, something feels off, there's no harm in being proactive, at least having a discussion with your OBGYN of like, is this something I should be thinking about? Do I need intervention at this point? You know, bringing it up. Or if you know that you have a known condition like PCOS or endometriosis or any kind of like maybe congenital or genetic factor or something like that, if you know that already, then the sooner the better. And being proactive about it is only going to help you out in the long run.
I love
Mm-hmm.
that you invite people in saying, you do know your body, because even in pelvic PT, I'm like,
Mm-hmm.
if something feels off, please
Yep.
check in. I know
Mm-hmm.
sometimes validation is not necessarily the same, like external
Right.
is not necessarily the same, but
Yeah.
I appreciate that.
Mm-hmm.
Yeah.
Also, you have shared so much. I feel like
Yeah, me
even
too.
on this
Too.
show, and
Very grateful.
yes,
Yes. No, thank you so much.
yes, thank you. Thank you for coming on, for sharing for
Yeah.
folks, and for giving us the heads up. And excited to hear more.
Yes,
Mm-hmm.
more to come, more to come.
Mm-hmm. Yep.
Thank you so much for your time. In the meanwhile, mamas, stay balanced. We're really grateful. Oh,
We
and
need
we
to know
want
how
to
to
make
connect.
sure we know how to connect with you. Yes,
Yes.
in the chat, in the captions.
Mm-hmm.
Please tell everyone, how can we reach you, Katerina?
Yes, so the three main platforms that I use, so I'm on Instagram at FB Fertility. I'm also on LinkedIn, just Katerina Jones. You can find me there. And then I will soon be launching a YouTube channel. So youtube.com/ at FB Fertility, where I'll be dropping lots of educational videos about many different like fertility topics and stuff like that, from a fertility nurse. So I'm really excited about that. That's coming in the next like 1 to 2 months.
Yes.
Have the zhuzh, you have it. Like you're great, such a great resource. I'm so excited to see you on there.
Thank you. Thank you. Thank you. Thank you. I
Oh,
appreciate it.
awesome, awesome. Well, thank you, mamas, for listening. Stay balanced, everyone, and we will check back in with everyone soon.